Hello, everyone. This is Mike Mulroney. Welcome to this episode of Shirley Talk. And Kelly's not here with us today. She's feeling a little under the weather. But today we have Mr. Ryan here, Ryan from Brown Cancer Center. And are you the pharmacist at Brown Cancer Center?
Yes, I'm one of 9 oncology pharmacists we have at the Cancer Center.
Wow, I didn't realize there would be that many.
Yeah.
Is it a 24-hour kind of thing, or?
Not for the not for the most part. Our schedule as pharmacists isn't 24 hours. Certainly there are some evenings where we're on call or answering calls or texts pretty late into the evening related to patients.
Yeah, right. Well, that's interesting. I didn't realize that a pharmacist would be on call, but I guess given that you work at the hospital, you have to make some certain exceptions and things like that.
Yes, absolutely.
So how did you get into being a pharmacist? And is a pharmacist at a hospital similar to like a pharmacist you would see at a drive-through at like a Walgreens or something? Is it similar or not even close?
It is very dissimilar. Traditionally speaking, or the most linear progression to the field, people would go through undergraduate as a physician would, and either get a degree in chemistry or biology, and then they would have 4 years of a doctor of pharmacy degree.
I'd be out. I had a hard time in chemistry.
And then after that, they do as a graduating doctor of pharmacy, they would have a year of residency, similar to physicians. And then to do oncology specifically, there'd be an additional year of residency where you're just working in the oncology field in the different kind of parts and areas that we work at.
So a pharmacist in general wouldn't have to go through all that extra residency type thing.
Correct. And that's really absolutely the pharmacists that work in retail, work at Walgreens and Kroger. They're on the front lines and they are working exceptionally hard.
Oh, yeah.
But we as clinical pharmacists or oncology pharmacists, we're more, shoulder to shoulder with the physicians and the nurses and, interacting with the patients regularly, doing all their education for their treatments, answering their questions, scheduling appointments and labs and writing orders. So it's a lot different.
So some of your other coworkers have been here, and when a person is diagnosed, there's usually a team of people that shows up in the patient's room talking about treatments and different things. Are you part of that team? Or are you kind of behind the scenes, or do you actually get to meet the patients and talk to them?
I would say it's a matter of layering. For the most part, new patients that come to the Cancer Center, all of their information will be reviewed by a group of people, including the oncologists, the dietitians, the nurses, and the pharmacists. And we are, making the diagnosis or making an additional diagnosis of what we think might be going on. And often we have a plan of care or a plan of treatment before going in and talking to the patient. And part of that is to present them with options. Certainly the patient's in charge, so we try not to bombard them with the information. But for the most part, at the Brown Cancer Center and University Hospital, being a teaching hospital, our oncology fellows, so our physicians in training to be oncologists, they'll see the patient first, and then they'll come out and have a conversation with the attending oncologist, and then he or she will go see the patient, and somewhere after that, I'll go in and talk to the patient about the treatment plan, side effects, how we give the medication, what to expect, and then work with the physicians to write the orders or enter the orders into the system.
Had you grown up wanting to be involved in the pharmacy world? Is that kind of a calling? Is it something that I'm just curious how you got into this. Is it something that you'd always wanted to do?
Well, I'd grown up always enjoying science and biology and chemistry, and probably somewhere late in junior high or early in high school, I was split between becoming a pharmacist or becoming a physician, and started my undergraduate. And I don't actually know at what point or where I diverged on my path to just becoming a pharmacist, but always wanted to do healthcare. Always wanted to try and improve patients' health and patient outcomes. Not until I'd been out working for some time did I transition to just focus on oncology. So I had a little bit of a less linear path than most oncology pharmacists would have.
So you went to your normal pharmacy school, then later on decided you wanted to focus on oncology?
Yes.
Is that okay? Yeah. So was there a reason why you went that way, or did something touch you, or somebody in your family have cancer and you just think, I got to be part of that?
No, I didn't. I wouldn't say that I knew anyone in particular. The hospital I was working at the time, I had started to help out in their cancer infusion center, and working with the team there, working with the physicians, I started to see the improved impact I could have on patients and the outcomes of these treatments for the patients. Not only the chemotherapy or the treatments, but also the supportive care medications for nausea and appetite and pain. I felt like I had a more immediate impact on patients, and there's also just the longitudinal interaction with the patients. Working in kind of any other environment, you might see a patient for a few days or a week or two, and then never really see them again. But the patients we see now, I see patients in the hospital, and then we're seeing the patients again in the clinic after they get discharged, and all of their additional follow-ups. So there's a much more constant environment of interaction with the patients.
You said the infusion center. So what's that look like? Unless somebody has actually dealt with cancer, I'm not sure. You hear your chemo and radiation, and I'd say the average person doesn't know what that means. Is it somebody that sits in, when somebody gets cancer treatments, chemo, for example, what is that? Do they have to sit in a room all day with an IV? Is it a pill? I had a friend that had colon cancer, and she was taking her, I think, chemo mobily. She had some pack that she carried around that looked like a purse, and she goes, "Oh, I'm getting my chemo today. It's been on all day." I'm like, "You're walking around like it's no big deal." So what's that look like? It sounds like treatments have changed over the years for her to be able to do that mobily as well.
Well, I think that you've described every possibility.
Okay.
Right there. I mean, for the most part, most patients, if they're getting intravenous medication, yes, they're going to be sitting in an infusion chair. And at the Brown, there's room for them and their spouse or a guest to join them, so they don't have to be there by themselves. It is a busy environment, but they have their own individual space, and depending on the infusion time for the medication. Some medications are only 15 minutes, some are 30 minutes, but there are some regimens where it's multiple medications and can take, 6 hours.
Yeah, I had a friend that he passed, unfortunately, but his wife took pictures of him. He was sitting there taking his treatments, and he had his laptop actually working while he was getting his treatments. And I won't never get. I thought that was the coolest thing, but he sat up, and it didn't seem to affect him that much. And it probably did. He was just one of those tougher guys that wasn't going to show it. But I thought that was really interesting. But, when my mom got sick, I didn't pay a lot of attention. And I kind of wear that burden with me. I think my dad went with her treatments, but I don't know. It's horrible to see people sitting there by themselves.
Yeah.
But I think about that often, that I wish I'd have been there to sit there and hold her hand. But I didn't understand the way it worked. I thought they gave you some pills and you went on your way. I had no idea you had to sit there with an IV and have the medication intravenously given that way.
Yeah. And that's just the outpatient side. We do have regimens or chemotherapy regimens that we have to give in the hospital as well that can take multiple days. So they're, admitted and committed to the hospital they're committed to that admission, I should say, for several days. And it can weigh on patients if they don't have somebody with them or something to do. I mean, it's the same room all day long, and we encourage them to get up and walk around and interact with the nurses. And I think that helps. I mean, just our encouragement to the patients kind of improves their outcome as well.
Absolutely. Yeah.
And speaking of oral drugs, as we're moving more and more towards more targeted treatments for cancer, where we can look at a patient's cancer cells and pick out different proteins and different enzymes that are different than the normal cells. Often now there are medications specifically for that. We call them mutations. So those changes in their cells, we have specific oral drugs that can target those. So in some cases, patients don't even have to come to the infusion center. We can give them an oral medication. but those aren't without their own risk. And we'd still need the same monitoring that we would need with IV medications as well.
So you see on the news these medications and it says it's lung cancer specific or liver. How does the medicine know? Is it looking for the cancer, or does it say, and I'm a dummy here, so is it rooting through the body and say, oh, here's the lungs, let's attach to the lungs and fight off anything on the lung? How does that know?
Well, I think that's a good question, and it is. Lung cancer is a good example. There are a half a dozen or more mutations we look at in lung cancer, and there are drugs, like I said, specifically targeting those mutations. And yes,
so it's looking for the cancer. It's not floating around looking for the lung and say, here we are, this is the direction I go. I mean, I know it's not that simple, but I was always curious how it knew, the medication knew where to go in the body.
It really doesn't. For the most part, it is just circulating through the system. And when that part of the blood gets to where the tumor is, if that mutation's there, it's going to...
That's when it hits it.
Yeah.
Okay.
And the unfortunate part, or the complicating part of that, is that some normal cells also have some of those similar receptors. So that's why we have to watch for side effects and problems from the drugs.
Mm-hmm. Are they getting better with side effects? It seems like you all have more medications now where if somebody's getting nauseated, they can add something for nausea and things like that. Are we getting better at making people more comfortable before and after the medication?
We are, yeah. We've I feel like every couple of years we come out with a new medication. There's really two parts to it. It's our job to try to prevent, the nausea from their chemotherapy. And then also it's as much our job as it is the patient's job to take their medications once they're at home to prevent the delayed part of the nausea, after they get their treatment. And, I'll tell patients openly and honestly, our goal is 100% you won't have any nausea, but that's always a lofty goal. And I think that we do a much better job of treating and preventing nausea than we did in the past. We're never perfect, but I think it's getting better. Alternatively, we're moving more into medications like immunotherapy. And with those medications, the side effects we're looking at, it's a complete shift from traditional chemotherapy, where we don't have to deal with nausea, but there's a whole nother list of side effects we have to watch for.
So what's the difference between that, immune therapy and chemotherapy? Or is there, I don't know enough about them to know the differences.
So with traditional chemotherapy, it is, our intent with traditional chemotherapy is to attack rapidly dividing cells, cancer cells. And I always describe chemotherapy as like a big bomb that's just going to hit, and you hope it hits the right place.
Yeah.
And very often it does, and we have success, but the bomb is causing problems in other places too. Whereas immunotherapy is a little more specific, but also as unspecific as chemotherapy can be. Immunotherapy is really harnessing the immune system or using a patient's immune system to find the cancer cells and attack it. So it's enabling the patient to treat themselves, really.
So obviously that's good. Obviously it's teaching the body to fight off the infection is what you're saying. Is that correct?
Yeah.
Yeah. So to me, that's how, if you get the flu, your body fights the flu as long as it's got a strong immune system. Right. So to me, that sounds like long-term, that's the route to go, because chemo, I don't know. I've been told you're basically putting poison in somebody's body, letting it fight the cancer, and then pumping it back out. Yeah. Is that similar? Or?
It is. Yeah. We have to, with chemotherapy, you want it to be there. You want it to target the cancer cells, but we have to do what we can to support the patient so that they get rid of it as well, and it doesn't linger. So
it's injected in the body, and then you got to get it out of the body.
Well, through the patient's own metabolism, with their liver getting rid of the chemotherapy, and then their kidneys, getting rid of the chemotherapy.
Yeah, your organs kick into overdrive, right. I guess, at that point when they notice something's not supposed to be there.
Yeah,
yeah. What about radiation at all? Are you just more on the medicine side of it?
Well, we work with the radiation oncologists as far as, some of our chemotherapy regimens are part of a multimodality, so a multi-part treatment, and part of that is radiation. And as a pharmacist, I'm not involved with the radiation part, but I am working with them to schedule the medications and deciding the doses of the medications that are appropriate to use with the patient's radiation. And
you usually have to back down on those kind of medications once radiation starts, or
not always. It depends on the cancer we're treating, and it depends on the drug we're using. In some cases, it's low doses of chemotherapy given with the radiation to help kind of boost the radiation's effects. Mm-hmm. So in those cases, radiation is the main treatment. The chemo is there just to make it work a little bit better.
Yeah. Well, that's amazing to get everything working together like that.
Yeah.
So how long has immune therapy been around? Has it been around for a very long time, or is it still kind of on the cutting edge of new treatments?
Well, do you want my modern times answer or the answer I would tell my residents?
I'm just curious. I don't know. I mean, has it been around for 20, 30 years, or is it,
Well, I'll tell this because it just brings me amusement, but the original immunotherapy was developed in the late 1800s.
Really?
There was a doctor that was injecting bacteria into patients' cancer, into their tumors. And the bacteria was making the immune system work, and it actually worked to kill the cancer. But he was actively infecting his patients with bacteria. So it eventually fell out of favor. Now, in modern times, probably the most recent immunotherapy would be a drug called ipilimumab or Yervoy.
Who names these things?
I don't.
I don't know how you even remember that. So, all right. So it was how long ago?
I think it was developed it came to market in 2010.
Okay.
And it was probably at the time it was one of the only new drugs for metastatic melanoma that's spread throughout a patient's body.
Right.
And it really changed the dynamic in metastatic melanoma patients. Not only because of its potential benefit, but also its serious potential side effects. Mm-hmm. Since then, we've had other medications, 2014, 2015. So it's really snowballed since then, I would say.
Over the past 10, 11 years.
Yeah.
Yeah, you hear people, is immune therapy kind of at the top of the list nowadays, or is it kind of a last resort?
I would say it's both. It can be both. Many of our regimens include immunotherapy right away, and that's to treat cancer that is spread. We also use immunotherapy. We call it in the adjuvant setting. So the patient's had surgery to remove their tumor, and then we give them immunotherapy for a year after that, kind of as a surveillance system for their immune system, so that their immune system can reduce the chances of the cancer coming back.
So it helps kick the immune system into overdrive, I guess.
Right.
Yeah, that's interesting. What are your and I'm just curious, it just hit me. You see a lot of people talking about cannabis and THC and stuff like that. Do you see any growth in that particular technology, or is that something a pharmacist? I'm sure you probably keep your eye on it.
Yeah, and it is something that we do look at. It complicates things for our patients when they're using, CBD oil or actual marijuana. On the simplest side, because of the potential interactions with their other medications and the interaction with some of their chemotherapy. And I don't ever, being frank, I don't discourage patients. They can do what they want, but I do want to make sure it's safe.
Yeah, for sure.
Certainly, I think the one issue and the one thing that we need to see is a well-controlled trial or a well-controlled study where we can actually see it. There's been a lot of small studies and a lot of anecdotal evidence that marijuana can help, but nothing that's been a big, robust trial that we can have a good, standing on for the results.
Yeah, I tell you, you see a lot of this stuff, and I don't know where I stand on it. I think if you've hit a point of no return, and there's really nothing else you can do, then by all means, give it a try. But we got to be fair and make sure, and like you said, controlled trials and studies to see if it's even actually having an effect.
Right. Right.
Because I'm sure people take the stuff all the time, and who knows? You don't know if it's the chemo fixing it or the THC or whatever it is they've decided to try.
Yeah.
But hopefully they'll do some controlled studies on that one day just to see if there's any value to it.
Yeah, I think it's important. I think it's important not only to, if it justifies the use, but also to give us at least a tracking of the safety.
Yeah,
for the patients.
There's so many armchair quarterbacks on every industry out there, and to have somebody say, "Oh, it killed my cancer," well, did it really? And I think there's potential. I'm not knocking it, but until there's some sort of controlled study, like you said, I don't know how you can determine the value of it.
Right.
Yeah. So these people walking around with the packs on that's doing chemo I don't know, you see some people taking chemo and they're so deathly ill and sick they can't get up, and then you got my friend like Amanda walking around like it's no big deal. Is that a little bit different type of chemo? You hear the ones called the Red Devil and all this stuff. I mean, why is she able to function and others seem like they're just completely can't move?
Well, I think it's a matter of
Is it a lower dose maybe?
It not necessarily it's a lower dose. What I'm guessing is it's a drug called fluorouracil. And it is
another name.
It's infused over 46 hours. So I would say she's probably getting some chemotherapy at the cancer center, and then they hook the bag up to her IV line, and then program the pump, and then she can leave with it. And for the most part, that pump at home, not a lot of side effects. It's that pump at home and the other drugs that she probably got before she left the cancer center. But that, for the most part, that regimen's tolerated pretty well.
Yeah.
Comparatively speaking, there are other regimens where they're not taking the pump home and, can produce some pretty good toxicity for patients, unfortunately.
Yeah. I read the book, Lance Armstrong's book. I don't know if you've ever read that.
I've not.
But he had the cancer, and in his book, he talks about the treatments were so bad that he would be curled up in a ball in the corner of his room, so sick. And then you see people like her walking around. They must have just hit him with everything to kill it.
Yeah, with the regimen that he probably got, it's a pretty robust, and it's pretty intense. It's a pretty intense regimen.
I think his was testicular cancer, maybe? Yeah.
And they use fairly high doses of chemotherapy in testicular cancer, so
yeah,
it can cause a lot of nausea, a lot of problems.
Of course, I guess it depends on the stage, but I was told the other day they don't go by stages anymore. Are they getting away from that, or like stage 1, 2, 3, and 4? Or?
Traditionally speaking, we still are. There are a few cancers, non-small cell lung cancer, for example, that we use an kind of an older staging system, but the standard staging is still used. It's still out there.
Yeah, I don't remember who told me that. I was trying to remember, but they were talking like, I don't know why they were getting away from it. To me, it seems like it works, but because maybe it's fear. Because once people hear stage 4, even stage 4 sometimes is curable. Right. The odds are a little harder, but I think it probably freaks people out when they hear stage 4, and you almost feel like there's nothing I can do.
I think, it might sound utopian, but I would like us to get to a point where stage doesn't matter. Mm-hmm. And where we can see a stage 1 patient or a stage 4 patient, and we can cure them both.
Yeah.
And ideally with the same medications and the same side effects. But that's a down the road thing that I hope we can get to.
Yeah. So are you seeing anything new out there? Obviously, do you have to take some sort of accreditation every year to stay up with all the new medicines, or how do you all find out about the new stuff?
Well, a lot of that's on our own time.
Are you and the doctors kind of talk about it and keep up with that stuff?
We do, and the benefit at the cancer center too is that we have over time we've had a robust study department, research department.
Because you all have come out with some cutting edge stuff over the years, right here out of Louisville, Kentucky, right?
Right.
Yeah.
Right. We were part of some of the original HPV vaccine trials, right. And specifically some of the immunotherapy trials we were part of initially. As an oncology pharmacist, we all get board certified in oncology. It's a national board certification program, and we have to do continuing education to maintain that.
But does that include newer stuff that might be on the market somewhere?
Yeah, it should.
Yeah.
It should.
Yeah.
Really for us, it's reading new articles, looking at the big medical journals, because they usually have the big, the more groundbreaking studies. But a lot of it's on our own time, and a lot of it is those kind of conversations, talking to the oncologist, talking to other pharmacists, because they might see something that we haven't seen yet, and then it prompts us to look more into it.
Is there a big central database somewhere? I mean, is it, you hear these other, like, what's the place in Houston? These different cancer centers. Why are they able to offer certain treatments other places can't? Is it because they have the equipment? I mean, I don't know. I'm just curious. You hear people go, I'm going to Houston, last resort. Why do people head different places like that?
Well, a lot of it is the availability of their studies. MD Anderson in Houston.
Yeah, that's the one.
They have a pretty robust research department, and a lot of it's funding. Research generally for the patients, they don't have to pay anything for the research, so that's a great thing. But
if you can get in.
Well, if you can get in.
Yeah.
But,
that and St. Jude, both great organizations. I can't imagine the waiting list they have.
Right. But for us, it's a matter of just us having the money to do the research and fund the research, because it's, if it's not sponsored by some major drug company, it's the hospital, it's the cancer center funding the studies to do these things. So.
Really? I didn't know that. Wow. So y'all pick whichever cancers, like, I don't know. It's you all picking apart the cancer and deciding how to treat it, I guess, sometimes?
A lot of it, yeah. A lot of it's new, just chemical entities that some researcher in a lab has found might work. And then they do the different phases of the study to get to the point where we can try it in the patients. They decide what dose and which types of patients it should be used in. And then generally that's, there's the study drug versus either nothing, or what would be the standard treatment for that same patient. Mm-hmm. And what we need to decide is that if we're giving them nothing, is this drug just as effective as nothing? And unfortunately, sometimes that's the case. And not to take away from the benefit of this and patients that question research is that it's improving our knowledge and our ability to treat the next patients.
Yeah.
And a broader population too.
Yeah, I think that's why my mom continued treatments, is for the research capabilities that could potentially help other people. Yeah. So there's, being an outsider in the medical field, I just envision a big database with all the things, and you Google or you type in, search lung cancer, and it lists 6 different treatments that anybody around the world could prescribe. And I guess it's not that easy.
Well, for not to sound like an egomaniac, but a lot of the database is just in our head, between us and the oncologist.
Oh, yeah.
But we do have resources. NCCN, the National Comprehensive Cancer Network, it's a big consensus network or consensus database that you can look at lung cancer, and it'll go through how to do the diagnosis. And then if it is this diagnosis, what do you do next? And if they have problems with that, what do you do next? And so it's a fantastic resource. And there's pretty much all of the big cancer centers in the country are part of that. And they all come together to agree on what these treatment plans should be. There's the American Society of Clinical Oncology, and they have guidelines, kind of established guidelines for treating. A lot of theirs is involved in side effect management or complication management. So that's another excellent resource that we can kind of go through stepwise, how we should be doing the treatment plan, or we should be managing problems for the patient.
Yeah. So when the doctor's meeting with the patients, do they come to you all often and say, this is what we got? Do you all make recommendations to the doctor sometimes on, this chemo seems to have historically worked better than this one for this type of patient? Because all patients are different.
That we do.
Okay.
We do. And occasionally it's that kind of opinion back and forth discussion. Occasionally it's us bringing up to the oncologist that there might be other issues that might prevent the patient from getting, say, immunotherapy or a chemotherapy due to, prior health history or other medications that they're on that might interact. And that's just part of us being part of that team, an important part of the team to add to the overall picture of the patient's care.
Yeah. Why do they call it the Red Devil?
So that's doxorubicin.
Is it big red injected through somebody's veins, or what is it?
Doxorubicin's a bright red drug. And
I've heard people saying, "Oh, they're breaking out the Red Devil today."
It's notorious. Yeah, it is notorious for side of nausea and problems with the immune system. Suppressing the immune system and everything.
So that's the Mac Daddy. If they pull out Red Devil, they're serious. Is that right?
Well, it like everything else, it has its specific utility, and it's an important drug in several cancers. It's the part of the regimen that would be used first in a lot of cancers. So it certainly has that reputation.
Yeah. What we do at Shirley's Way is we try to help people financially with things. If somebody's prescribed something that the insurance company just won't cover, is there different programs out there that people could look into that might help them with co-pays and things like that on medications?
Well, on the simplest level that a patient can do is if their doctor is talking to them about a new medication. Almost every new medication has a website, and they have a patient website, and from there they often have a patient assistance website.
Okay.
But that's a lot of steps, and the patient's already dealing with so many other things at one time. So at the Brown Cancer Center, we have an excellent medication access technician, and she is involved in almost every patient. We have two technicians, I should say. I'm sorry. One does the oral medications, so she works with the pharmacies. She works with the pharmacy insurance to help the patient pay as little as they have to.
Right.
And if she can't do that based on their insurance or the pharmacy, she'll reach out to the drug company for copay assistance or copay cards or coupons. We have another technician that deals with the IV medications, and it's really the same thing.
So they're kind of a medication navigator, I guess
Right.
you could say. Well, that's
Right.
good. I don't think I knew that. So that's a fantastic resource.
Yeah, it really is, and it takes so much burden off the patient, because and occasionally they do everything they can, and there's still a high cost, and then we go from there. But they take a lot of that legwork out, so the patient doesn't have to.
Mm-hmm.
And not every patient is computer or internet savvy, and not every patient has the time, because we do have patients that have active cancer, and they're trying to work, and they're trying to take care of their family.
Mm-hmm.
So they don't need to be filling out a bunch of paperwork and being on hold with a drug company or an insurance company when there are people that can do that to help them.
Yeah, because that can turn into 27 phone calls in a day.
Right. And 27 hours in a day on the phone.
I just it's so crazy. I just wish it could be simplified.
I do too.
There has to be a way to simplify this stuff, but I think if anybody had anything at all, obviously the treatments are rough, but if there was a way to simplify the paperwork and everything else, it would probably be so much less stress on everybody.
Right.
Maybe we'll get to that one day.
I hope so too.
Yeah. Well, thanks for coming in today. Is there anything else that you'd like to talk about today that you all do that might set you all apart from the others? Or
I think that like I said, I think that our ability to work with the oncologists and work with the patients, and it's the rewarding part of my job. And very often I'm the last person the patient sees before they leave their room to go home after their initial appointment, because I'm the last one to go in to talk to them about their medication.
right.
And, on several occasions I've had patients say, I don't remember anybody else's name that I talked to today, but I remember Ryan, because he was at very least because I was the last one to see him. So, and, just trying to keep that relationship up with the patients, and talking to them as they go through their treatment.
Yeah. I'm sure the other hospitals do similar stuff, but the one thing that I really appreciated when my mom was at the Brown was the team approach.
Yeah.
Everybody there, whether they're having a bad day or not, I felt they were there for that particular person no matter what. And I'd say patients really do appreciate that. So,
thank you.
Yeah. Well, thanks for coming in today so much, and we'll get some of your other colleagues in here eventually too. So a lot of y'all have been coming in, but thanks so much. It was very, like I said, I don't think the general public realizes what treatments look like.
Right.
Is it a pill? Is it a liquid? But a lot of it is sitting there. It could be a large part of the day getting their medication. So.
Yeah.
Well, thanks for painting that picture for us. Thanks for sharing your knowledge, and thanks for all you do.
Thank you. Thank you for having me in today.
If you want to help support Shirley's Way, I'll give Kelly's commercial since she's not here. Go to shirleysway.org and set up. We're really pushing hard for $10 monthly donations right now. So get out there, sign up to become a monthly donor, and we'd love to have you. We got several small businesses signing up for $100 a month to support and sponsor some of the gaming and raffle activities that we do on a regular basis to raise money. So go out to shirleysway.org. You can see all that information, and thanks so much. We'll see you next time.